connected. So please take all of your questions and type on the Q&A chat box. Today we have amazing panelists. So we have a lot of people to discuss all of your questions, and I'm sure this is going to be amazing. Today we're going to talk about what is totally anomalous systemic venous connection, and we have more to come from Dr. Anderson. So every Friday we already are planning the March topics. This is going to be amazing. I want to invite all of you to watch tomorrow, to join us to the Da Silva Center for Absent Anomaly Symposium. It's going to be a very nice symposium. Dr. Anderson is even one of the speakers. I'm sure this is going to be amazing, and we are very proud to support and to stream live this webinar as well. We are continuing with our fetal cardiology series. So next meeting is going to be on February 25th. So please join us. And Dr. Silverman is continuing to have meetings with us. So next one is going to be on the 8th of March, talking about anomalous pulmonary venous connections. Please join on this amazing series correlating echo and morphological features. We are planning much more for you during this year. Dr. Mary Coyne is already agreed to continue her series. So I'm sure this is going to be amazing. So please type your questions and stay with us for the discussion in the end. This is going to be very good. And Dr. Giovernovsky is going to talk about the World Congress as well.
Well, good afternoon to you, ladies and gentlemen. This afternoon, we have a very interesting lesion to discuss. And as you can see from my images, it is totally anomalous systemic venous connection. Now, I'm sure very few of you will have seen an example of totally anomalous systemic venous connection. So as to explain this entity and to show you how to diagnose it, I'm going to be working with my good friend and colleague, Saurabh Gupta, who you heard a couple of weeks ago when we discussed the sinus venosus defect. Now, Saurabh does have experience with this entity, and he's going to describe to you the problems in its diagnosis, and he'll discuss with you how it may come about. So it is my task to set the scene as to what is a totally anomalous systemic venous connection, and to give you at least some indication of the potential developmental problems that might have to ensue so as to produce this lesion. So we need to start off by asking the question, as you see on the screen at the moment, what precisely is an anomalous venous connection? And I would suggest to you that we find an anomalous venous connection when a vein, or more than one veins in this instance, veins, are connected to a morphologically inappropriate atrium. So we can have various types of anomalous venous connection. It also follows, however, that if we are going to demand that the veins connect to a morphologically inappropriate atrium, the starting point for our diagnosis has to be the recognition of atrial arrangement. So I'm going to start off by discussing with you that point. How do we recognize atrial arrangement? And here, the important principle is the one that is called the morphological method. Now, many of you may already know about the morphological method, but for those of you who don't, let me emphasize again the importance of this principle. It was introduced by my good friend, Richard van Praag. And Richard introduced this concept so as to be able to provide uniform definition for components of the heart wherever we find them. And the point that Richard made was that in order to identify these components, we should not use a part of themselves which is itself variable. It's interesting to look back at this concept because Richard made this important point when he was discussing one of the papers that I wrote myself. It's a long time ago now. It's a paper I published way back in 1979 with Barry Keaton, the pediatric cardiologist who worked in Southampton. He was working with us at the time at the Brompton Hospital. And we wrote a manuscript describing what we called the univentricular heart of right ventricular type. And this is a letter that Richard and his colleagues wrote to the journal, pointing out the deficiency in the way we made this definition. Because Richard pointed out that we were trying to deny the left ventricle its ventricular status because it lacked its inlet component. And he made this very important point that the inlet component itself is variable. So we should not be using that to define another variable, the status of the ventricles themselves. And as we will see, this is particularly important in the setting of anomalous systemic venous connections. And I can illustrate that point by showing you this picture. Now, many of you hopefully will immediately recognize that what I've done here is that I've taken the heart in the setting of a specific lesion, totally anomalous pulmonary venous connection, and I flipped the heart out of its pericardial cradle. This is the so-called Taussig maneuver. It was Helen Taussig who pointed out the importance of this maneuver in identifying in the autopsy room totally anomalous pulmonary venous connection. Because when the pulmonary veins are not attached to the left atrium, there is nothing to anchor the heart within its pericardial cradle. So this is what I've done with this particular data set. I have flipped the heart out of its pericardial cradle. So you're looking into the back of the mediastinum. And there you see the pulmonary veins. The pulmonary veins are coming together. They're forming the upside down Christmas tree. And in this instance, the veins are extending through the diaphragm and they're draining into the hepatic portal system and thence to the liver. And this is the importance of the morphological method, because there are many who suggest we should use the veins to determine what is the right and what is the left atrium. So there are still those who say that the left atrium is the structure receiving the pulmonary veins. So ask the question, what would happen here in the setting of totally anomalous pulmonary venous connection to the portal venous system? In this instance, of course, if we said that the pulmonary veins were going to determine the anatomy of the left atrium, it would be the liver that would become the left atrium. And that is obviously a nonsense definition, and it simply shows that in this instance, we cannot use the veins to determine the identity of another structure, namely the left atrium. Because there you see, we can identify the left atrium even when the pulmonary veins are draining to an extracardiac site. And that is the importance for today's discussion of the morphological method. So it follows that if we are to recognize anomalous venous connection, we have to start by determining atrial arrangement. And you've already seen now that we cannot use the venous connections so as to make that decision. And I hope that you all know by now that in fact it is the atrial appendages, the most constant component of the atrial chambers, that are used to arbitrate atrial arrangement. So let me show you this normal heart. It's a picture of the atrioventricular junctions, as is usual now when I show you pictures of specimens, I use the exquisite photographs that are made by Diane Spicer. And here Diane has removed the atrial myocardium. She's taken away the arterial trunks at the level of the sinutubular junctions. And she's photographed the heart, the base of the heart, from its atrial aspect. So here you are looking down on the right atrioventricular junction. And we know that this is the junction of the morphologically right atrium because we see the pectinate muscles within the atrium are extending all the way around the right atrioventricular junction. And this is the feature that tells us we are dealing with a morphologically right atrium. Because in this normal heart, if we look at the left atrioventricular junction, there we see the tubular mouth of the appendage on that side. And we know that in the normal situation, the pectinate muscles are confined within this tubular appendage. In fact, in this heart, there's a minimal spill of those pectinate muscles, but almost the entirety of the left atrioventricular junction is smooth. It doesn't have any pectinate muscles, telling us that this is the morphologically left atrioventricular junction, and the chamber Diane removed was a morphologically left atrium. There is, in fact, another clue that here we are dealing with the morphologically left atrioventricular junction, and that is the presence of the coronary sinus. Now, the coronary sinus is particularly important for today's discussion because what you can see in the specimen here that Diane has prepared for you is that although the coronary sinus is occupying the morphologically left atrioventricular junction, it is opening into the morphologically right atrium. But the presence of the coronary sinus in the morphologically left atrioventricular junction is another indicator that it is the left side of the heart that is showing morphologically leftness. And that is going to be very important in the discussions that you'll be sharing with Saurabh. So it is the extent of the pectinate muscles that permit us to distinguish between the morphologically right and the morphologically left appendages. So in the usual arrangement, as I'm showing you in this drawing, it is in the right-sided appendage that the pectinate muscles extend all the way around the junction, as I've just shown you in that very beautiful photograph taken by Diane, whereas in normal heart, the left-sided atrioventricular junction is smooth. So that is what we call usual atrial arrangement, situs solitus, if you will. But as you are all aware now, I much prefer to describe these features using the English language or its American version. So if we look at the rarer form of atrial arrangement, this is the mirror image of the usual situation. So in this instance, the atrial chamber that has the pectinate muscles running all the way around the atrioventricular junction is left-sided. The atrial chamber that has a smooth inferior vestibule is right-sided. Pectinate muscles are confined within the tubular appendage. So this is mirror-imaged atrial arrangement. Situs inversus, if you will, but in fact it's not upside down, it's mirror-imaged. Now, what is important for today's discussion is to recognize the other two variants of atrial arrangement. And by now, I hope you all know what is coming. Because you know that in the setting of so-called heterotaxy, there are two significant variants. In the one, the pectinate muscles extend around the junctions on both sides, and that is what we call right isomerism. The appendages are isomeric, and significantly, it is only the appendages within the heart that are isomeric. The venous connections are markedly variable. And the other option in the setting of so-called heterotaxy is for there to be left isomerism. And this is when both of the vestibules are smooth, both of the appendages are tubular, the pectinate muscles are confined within those tubular appendages, left isomerism of the atrial appendages. So the key to differentiating totally anomalous systemic venous connection is to distinguish between these four variants. Why is that? Well, from what we've said already, you will now appreciate that the systemic veins can only be anomalously connected when there is a morphologically left atrial appendage, because they need to be joined into that morphologically left appendage so as to be anomalously connected. It also follows, of course, that the pulmonary veins can only be anomalously connected when there is a morphologically right atrial appendage present. So it follows from this that totally anomalous systemic venous connections can only be found in the setting of usual or mirror-imaged atrial arrangement, because if you have bilateral morphologically left atrial appendage, the systemic veins will be anomalously connected wherever they are. So what is normal systemic venous connection? So normal systemic venous connection is when both of the caval veins, along with the coronary sinus, connect into the atrial chamber, which has a morphologically right appendage. So now we need to determine precisely what we mean by normal systemic venous connection. So again, I can show you this very pretty picture from Diane. And there you see the pectinate muscles that are extending all the way round the morphologically right atrioventricular junction. And this is telling us that we have a morphologically right atrial appendage. So now coming into this chamber, which we know is the morphologically right atrium, we have the superior caval vein, we have the inferior caval vein. And as we look into this morphologically right atrium, we can see other important features that are marking the boundaries of what we can now call the systemic venous sinus. And they are the venous valves. And they are important because a prominent venous valve guarding the mouth of the inferior caval vein can deflect the inferior caval vein into the morphologically left atrium, giving the impression of anomalous connection of the inferior caval vein, even if it retains its connection into the morphologically right atrium. So that's an important point to bear in mind as we discuss totally anomalous systemic venous connection. Equally important, if we are to have totally anomalous systemic venous connection, not only must the superior caval vein, the inferior caval vein be connected to the morphologically left atrium, so must be the coronary sinus. And this is going to be discussed in depth by Saurabh. To have totally anomalous systemic venous connection, all three of these veins, superior caval vein, the inferior caval vein, coronary sinus, must connect into the morphologically left atrium. So we have to think, how is it that this might come about? So let's look at how these normal patterns of venous drainage are established during cardiac development. Now, those of you who have been watching our presentations over the recent weeks will know that we've been depending very much to understand normal development on these very beautiful interactive PD files that have been made by my colleagues working at the University of Maastricht, Professor Wout Lammers, Dr. Jill Hicks-Poors. And I'm going to depend upon their reconstructions again. So those of you who have been watching us will know that we have reconstructions that move from 4 weeks of development. The arrangement, as you see here, I'm showing you the reconstructed embryo here. This is what we call Carnegie stage 10. And if we look at it, it doesn't appear much like what we expect embryos to look like at this early stage. But we can recognize the head folds, and there is the heart within its pericardial cavity. The situation at this stage, however, is dominated by what's going on in the body of the atrium, of the embryo rather. There you see the dorsal aorta, but here is the yolk sac. And you see that there are a system of veins on the surface of the yolk sac that are draining back into the heart. And these are the vitelline veins. There's another series of veins that are present bilaterally, and these veins are bringing the blood back from the placenta. So this is where the embryo is beginning to get its nutrients from the mother. And so the umbilical veins, the vitelline veins are bilaterally symmetrical. They're bringing back the blood to the heart. As yet, there are no veins coming back to the heart from the body itself. So one of the beauties of these interactive PD files is that I can take them apart because Jill and Wout have segmented the different components so we can look inside the heart, which is what we're going to do for the rest of the time as we discuss the development of these channels, and we can look at the venous and the arterial channels. So here now you see the cavities of those veins bringing the blood back from the placenta, and you can see now that they are bilaterally symmetrical. There are those veins on the surface of the yolk sac, and they are coming together to produce the venous tributaries that are feeding into the caudal margin, the heart tube. The heart tube at this stage is more or less straight, and its larger part is made up of what will become the left ventricle. At its cranial end, we see that the beginning of development of what eventually will be the outflow tract of the right ventricle, and that is feeding the symmetrical aortas. So this is what we see at Carnegie stage 10, about 4 weeks of development. And things happen relatively quickly at this stage. So here only 1 day has gone on before we move into Carnegie stage 11. And the significant point is that we now see evidence of the ventricular loop, supporting the outflow tract, giving rise to the aortas. The venous tributaries have also enlarged, and they are now receiving what we call the hepatocardiac channels. And the hepatocardiac channels are providing a unified channel to bring back the blood from the yolk sac, from the placenta. But now for the first time, we see in the embryo the formation of the veins bringing the blood back from the embryo itself, and we call these cardinal veins. And they're all coming together into the atrial component of the heart tube. We can move on one more stage, Carnegie stage 12, and now you see that the embryo is beginning to look a little more like what we expect it to. The head is beginning to turn, the brain is developing. At the back, we see the neural tube. The dorsal aortas are still bilaterally symmetrical, but now we see the pharyngeal arch arteries that are percolating through the pharyngeal mesenchyme from the outflow tract of the heart itself, which is contained within its pericardial cavity. But now you see on either side in the body of the embryo, we have the cardinal veins, and they are now bringing the blood back from the embryo itself to what we can recognize as the sinus horns. So I've done the same thing I did a moment ago. I deconstructed this embryo to show you what's going on in terms of the cavities, concentrating on the venous pole of the developing atrium. So again in purple, see the vitelline vein, the umbilical veins rather, and the vitelline veins. They are coming together into the hepatocardiac channels. But now the venous inflows also receive the blood from the embryo itself through the cardinal veins. Now the key point at this stage is that the veins drain symmetrically through what we can call the horns of the systemic venous sinus. On each side, they are draining into the body of what will become the atrium. Now remember, we recognize the atrial chambers in terms of their appendages. And now, for the first time, we can see the beginning of ballooning of those appendages, and they eventually will permit us to distinguish between what is morphologically right, what is morphologically left. So if I summarize what I've told you to date, Carnegie stage 12, we have symmetrical systemic venous return. So the key point of normal development in order to permit atrial septation is to remodel the systemic venous sinus so that it opens to the right side of the atrium. And that is what happens on the next two stages of development. So let me show you again what is happening at Carnegie stage 12. This is about 30 days of development. Remember, we have the body of the atrium. The atrium itself is connected to the dorsal mesocardium at this stage, is connected to the body of the embryo at this stage through what we call the dorsal mesocardium. And that is a midline structure. But now, as we look at the connection of the systemic venous tributaries, we can recognize a left sinus horn, and we can recognize a right sinus horn. And each horn is receiving the venous tributaries on that side from the cardinal veins, the umbilical veins, the vitelline veins. We still have venous symmetry at this stage. But here is the key point. In the next stage of development, about 32 days, we're halfway through the 5th week of development, that left sinus horn has become incorporated into the left atrioventricular groove so that it drains into what will become the morphologically right atrium. And I've already told you the importance of that feature. So now the body of the atrium is still connected to the body of the embryo through the dorsal mesocardium, but in the middle of the dorsal mesocardium, we see what will become the opening of the pulmonary vein. But what has now happened? The left sinus horn has incorporated itself into the left atrioventricular groove so that it opens into the systemic venous sinus, itself opening into what will become the right atrium. And I can show you what has happened in this cut that is taken from an episcopic data set. I've been showing you these also. I'm showing you now this in the frontal plane. You're looking at it from the front. So now what you see to your left hand is the right side. What you see to your right hand is the left side. And we can now recognize the boundary between the systemic venous sinus and the right atrium. And that is formed by these venous valves. And if we look within the confines of the venous valves, we see the opening of the superior caval vein, the opening of the inferior caval vein, and there, running through what will be the left atrioventricular groove, we have the left sinus horn. And note that it has its own walls. This is another key to normal development. The left sinus horn from the outset, which will become the coronary sinus, has its own walls. But the other key point, having transferred the systemic venous sinus to the right side, now we are able to septate the atrial chamber by formation of the primary septum. So let me show you that transfer of the systemic venous sinus again, looking at the mouse heart. Here we're at the stage where we have a relatively straight tube. Coming into the back of the tube, its caudal component, we have the body of the primary atrium. And if we cut off the atrium, the ventricle rather, we can then look into the developing atrium. And this is what it looks like in a scanning electron micrograph. There is the gut, and there you see the connections between the atrial walls and the body of the embryo through what I told you we call the dorsal mesocardium. But you're looking into the back of the atrial chamber. At this stage, you see the right sinus horn, you see the left sinus horn. And in order to septate the atrial chamber, we have to move that left sinus horn to the right side, and you've seen that that takes place during the 12th and 13th stages of human development. In the mouse, it's happened by embryonic day 10.5. So now you see those venous valves marking the boundary between the systemic venous sinus and what will become the morphologically right atrium. And now also, if we look into the back of the embryo, we can see these ridges that are flanking the dorsal mesocardium, and the pulmonary vein will open between those ridges, and the primary septum will develop in such a way as to put that opening into the left atrium. Now that in itself has been controversial in the past, and it has been suggested that the pulmonary vein originates from the systemic venous sinus itself. In fact, we know that is not the case. This is work I did with my colleagues in Amsterdam, where they were able to mark the lineage of the components that form the atrial chambers. So here they've colored this section so as to show NKX 2.5, which is showing you the regular myocardium. And you see it is not marking the horns of the systemic venous sinus. What it is marking is the boundaries of the dorsal mesocardium, and that is where the pulmonary vein will enter the morphologically left atrium. My colleagues in Amsterdam were then able to stain the section that was next to this one in a serially sectioned human embryo. And they marked that with TBX18, a transcription factor, which shows the systemic venous sinus. And you see it has not marked the opening of the pulmonary vein, but it has marked both the right and the left horns of the systemic venous sinus. So this shows us that in the human, the pulmonary vein does not develop from the systemic venous sinus. And it shows that as it enters the left atrium, the left sinus horn has already been connected to the systemic venous sinus, as we've seen. So having shifted the systemic venous sinus to the right, the primary atrial septum is able to grow in such a way that along with the vestibular spine, it can commit the pulmonary vein into the left atrium. And that's what it does at this stage, Carnegie stage 14. We're looking at this now in a long axis section. This is equivalent to the parasternal long axis echocardiographic equivalent. So you can see the left atrium, the left ventricle, the cushions within the atrioventricular canal. The sinus horn is now in the left atrioventricular junction, and there is the opening of the pulmonary vein. Note that it starts off very close to the atrioventricular junction. And it is not until relatively late in development, as you see here in what I'm now showing you in a four-chamber section, the pulmonary venous component has migrated to reach the roof of the developing left atrium. And it is only subsequent to that migration that we see the superior interatrial fold, often called the septum secundum, but much better termed, as I just said a moment ago, the superior interatrial fold. So that is how we get normal venous connections. So what Saurabh is now going to show you is how we can recognize anomalous venous connections. So let me emphasize again, first of all, we need to determine atrial arrangement, because when you have left isomerism, it is possible for all of the systemic veins, along with the pulmonary veins, to connect into a left-sided atrial chamber. But when both of the atrial chambers in that setting have morphologically left appendages, that is not totally anomalous systemic venous connection. It is anomalous venous drainage, but in the setting of left isomerism. So what Saurabh is going to show you, we can only have totally anomalous systemic venous connection when we have usual atrial arrangement. So the starting point of our analysis has to be recognition of atrial arrangement. To do that, We must recognize the atrial appendages because they are the most constant components, and it is use of the most constant component that is the arbiter of atrial arrangement. So now Saurabh will take you forward and explain all about totally anomalous systemic venous connection.
Hello, everyone, and greetings from India. I'm following Dr. Anderson, so he has taken us through the development of systemic venous channels in the heart. And now what I will do is, before I directly jump onto totally anomalous systemic venous connection, I'll take a slightly different approach, go slightly back how I started recognizing these systemic venous anomalies, and then take you to TASVC as we are discussing today. So this was the first encounter of, in my initial days after my training in cardiology, when I encountered a case of right superior cable vein to left atrium. And then I realized that saline contrast echo is quite important. And another useful clue, which may tell us that the patient may be having systemic venous anomaly, is dilatation of left atrium and the left ventricle. As you can see in this subcostal view, the contrast is injected in the right arm, and then we are filling the left atrium and the left ventricle intensely with some bubbles going on to the right side. Now, this was another case which was happening around that time when we detected iatrogenic connection of IVC to the left atrium following ASD closure. And this patient presented quite late after almost 15 years of surgery with polycythemia and stroke. And that's how I got interested in systemic venous anomalies. So what I made out of these anomalies is that cyanosis may be the only finding in these patients. Right to left shunting is not that obvious as in other conditions where there is cyanosis. Dilated left atrium and left ventricle is an important clue to identify such lesions, and saline contrast echo is quite useful if we use it carefully. And hypoplasia of right atrium and right ventricle may coexist depending upon which vein or which all veins are anomalously connected to the left side. Now, some few more questions were coming to my mind when I was going through the systemic venous connections, and I thought that, is anomalous connection always abnormal? Like here, the left SVC is connected to the coronary sinus, but it opens into the right atrium. So although it is connecting abnormally, it is draining normally. So should we call this as abnormal? Is it as abnormal, this retroaortic innominate vein or retroaortic brachiocephalic vein? Is it as abnormal as a superior cable vein to left atrium? And that's how I started thinking whether how we approach systemic venous anomalies, should we take a different approach to these conditions? Now, what became obvious to me was that anomalous connection is not equivalent or same to as anomalous drainage. Anomalies, of course, are usually not as serious as the anomalies of connection and the drainage. And saline contrast echo remains quite useful if done properly. So in 2014, I encountered a patient who was a 13-year-old girl with class 3 dyspnea, deep cyanosis with a saturation of 60%. And she was referred with hypoplastic right ventricle and tricuspid valve. And she was referred as a single ventricle physiology. She had all the signs of chronic hypoxia, and a P2 was soft, and there was no murmur, no heart failure. And as you can see, this was the X-ray, which shows that it was a lateralized arrangement where the bronchi arrangement is like usual, as we see in usual arrangement. Now, this was the ECG. As you can see over here, that there is junctional rhythm and P waves are not seen well. So there is some form of isorhythmic AV dissociation which is going on. And another thing which is important here is, if you can see over here, the R in the QRS complexes in the anterior precordial R waves are not seen, and there is absence of S wave in the V6, which again suggests that there may be something wrong in the right ventricular cavity. Now, this was the echo, which shows that the usual arrangement of vascular channels, this is the aorta and this is the inferior caval vein. I'm sorry for these images that Apex is on this side, but I have put a marker for those who do the correct format. But for the time being, I'm explaining the same way it has been recorded. So this is dilated left atrium and the left ventricle. And you can see this is this diminutive right atrium and the right ventricle. The tricuspid annulus was measuring minus 2.3 Z-score and mitral valve was plus 2.4, and which suggests that there is hypoplasia of the right ventricle and there is dilatation of the left ventricle. There was no pulmonary stenosis. Pulmonary arteries were confluent and Magoon's ratio was 1.8, and arch was normal, and there was a connecting cava and the right superior caval vein was seen. So this patient had usual situs soletus based on the arrangement of aorta and the inferior caval vein, liver and stomach on X-ray, and left and right bronchus. The connections in AV and VA were concordant, and the relationship of the great arteries were normal. There was no obvious intracardiac shunt in this patient. Despite that, patient was having deep sinuses. There was no PS to suggest that there can be a shunt which we might not have picked within the heart. And the left atrium and left ventricle were dilated. So these two things were quite striking, that there was no intracardiac shunt and the chambers were left-sided were dilated and right side was hypoplastic. So based on the previous experience, I started thinking whether I'm dealing with a patient of anomalous systemic venous connection. And as I said, I used saline contrast echo. Now, when it was done from both right and left arm, what happened was, if you see it again, if I start from here, when the contrast is first appearing in the heart, it appears in the left atrium, then it goes to the left ventricle. Only later, few bubbles enter onto the right side. Now I'll show in running, and later the right atrium is being filled with this contrast, saline, and the right ventricle, and you can see the discrepancy very obviously. So although we did not pick an AST or interatrial communication, there was a shunting which was happening from left atrium to right atrium, which conventionally we say left to right shunt and not right to left shunt. So we were dealing with a situation where systemic veins were connecting to the left atrium and there was interatrial communication which was shunting left to right. We did the same from the leg, and as you can see, these are the hepatic veins. And once we sweep anteriorly, you can see that it first fills the left atrium and then it connects to the left ventricle. So it suggests that both the superior caval vein as well as the inferior caval vein was connecting to the left atrium. But there were some unanswered questions. Where does the coronary sinus drain? What is the arrangement of the atriums, whether it is really usual or mirror imaged or isomeric, because we have not seen the appendages as was highlighted by Professor Anderson. And the bigger question was how to manage this patient. Can we correct? Is PA pressure low enough to allow a bidirectional Glenn path, or can the patient be treated as 1.5 ventricle? These were the questions. So we took the patient up for cardiac catheterization. And as you would clearly see here, that the IVC and the hepatic vein both are connecting to this large atrium, which then connects to the left ventricle. And if you see carefully, there is this appendage which is being filled, and this bears the characteristics of left atrium. And therefore, what we said is that this is the inferior caval vein which is connected to the left atrium. This was the injection in the superior caval vein. So connecting cava, again, you can see the same thing. It fills the same atrium, and there is some reflex into the hepatic veins as well. If you see carefully, there is some reflex into the pulmonary vein as well. Now, this was a left ventricular angiogram. There is no ventricular septal defect. Now, the next problem was how to reach pulmonary artery in this patient, because both the systemic veins were connected to the left atrium. There was no access to the right ventricle through the veins. So we decided to go retrograde. And this is how we entered from aorta through the aorta to left ventricle to left atrium, and we entered into the pulmonary vein. And as you can see over here, this pulmonary vein is connecting to the same atrium, which is receiving the hepatic veins. This reflex tells us very clearly, and the position of the atrium is also suggestive that we are into the posterior atrium, suggesting that the pulmonary veins are also connected to the same atrium, which is the left-sided atrium. Now, the bigger question was, where is the coronary sinus? Luckily, we could enter the coronary sinus. And if you see, This is the coronary sinus, and in the reflux, it again fills the same atrium which was filled in all the other injections. It even fills the same appendage which we were seeing in the initial injection when it was made in inferior caval vein. Now, but we wanted to get into the pulmonary artery. So we, from the left atrium, we entered through the interatrial communication into the right atrium, went inside the right ventricle, which was hypoplastic, and it was giving rise to the pulmonary arteries. With some difficulty, we could enter the pulmonary valve, crossing all the 4 valves, aortic valve, mitral valve, then tricuspid valve and pulmonary valve to enter into the pulmonary artery to take the PA pressures, because I thought that that is mandatory before we can decide any plan for the patient. Now, this is just to show that this patient also underwent CT, but as you can see, this is such a diminutive right atrium. To say for sure whether this is really a right atrial appendage or whether it can be a left atrial appendage were difficult, but looking at the shape, it looks as if it was a right atrial appendage and this patient had usual arrangement of atrial appendages. Now, this was the pressure data, which showed that pulmonary artery pressure is 21 and PVRI was 6.5 Wood units. The options we had were whether we do rerouting of all the systemic veins. I mean, it was inferior caval vein and superior caval vein with coronary sinus, and do epicardial pacing for the rhythm abnormality. But we decided, since the ventricle is too small, let's do 1.5 ventricle repair by doing a Glenn and rerouting of this, maybe in a staged-wide manner. But when we send the patient for surgery, the surgeons felt that RV is too small, and they ended up doing bidirectional Glenn with atrial septectomy. Now, this is what happened after the surgery. Patient had 80% saturation immediately post-op. The Glenn circuit was functioning well. And as you can see, this is the wide atrial septectomy, which is allowing flow to occur across the atriums. And you can see the right ventricle is already increased in its size. 18 months follow-up, you will see that right ventricle has grown in size significantly. Patient was in class 2 with a saturation of 84% and pulmonary artery pressure was normal. Now, this was done, the patient was seen in 2014. So these all echoes, these 2 echoes are in 2016, and you can see how diminutive this right ventricle was in the pre-op status and how much grown it is later on after the surgery. And at this point in time, the tricuspid valve annulus measured 20 millimeters, while the mitral valve annulus measured 29 millimeters. And I thought that this patient can go for complete repair with 2 options: one, BDG takedown and complete repair, or to do 1.5 ventricle repair. But after discussing with surgeons, we felt that it may be better to go for 1.5 ventricle repair, do ASD closure and rerouting of inferior caval vein and coronary sinus. Now, 4 years post this 1.5 ventricle repair, patient is in class 1, saturation 95%. Now, coming to another case, which will exemplify why it is important to differentiate between usual arrangement and isomerism. This patient was a 2.5-year-old girl, known cyanotic with reduced pulmonary blood flow. Echo somewhere else showed TOF with severe PS, saturation was 80%. But this was the X-ray. As you would notice that this X-ray is not typical of tetralogy of Fallot. In addition, like the previous case, S waves are not prominent, suggesting that there is again something wrong with the right ventricle, and the rhythm abnormality is also there. If you see, the P waves in lead 2 are negative, suggesting that it is not the sinus focus of the P wave, it is coming from low atrium. And that again suggests that there is something wrong in the right atrium, which is not seen usually. Now, this patient also had interrupted inferior caval vein with azygous continuation to right superior caval vein. There was no connecting cava. All pulmonary veins were to LA, and there was concordant AV and VA connections. Now, this was the echo, which you can see here. The left atrium and the left ventricle is again enlarged. In comparison, right ventricle and the right atrium are small in size. This is the ventricular septal defect. It is better seen in this view. There is a large non-restrictive perimembranous ventricular septal defect. Right ventricle is much smaller compared to the left ventricle, which is not the case in usual tetralogy of Fallot. Mitral valve annulus measured -1.52 Z score. Tricuspid valve was hypoplastic and mitral valve was plus 2.3 Z-score. Again, we did the same saline contrast. I'll show you again here by pausing it. And you can see the sequences again. The contrast first appears in left atrium, goes to left ventricle, and then it fills the right ventricle. Again, if you look at the flow characteristics, it is the flow from the left ventricle to the right ventricle and not the other way around. So which means again here we are having a condition where the patient is having cyanosis, but the shunting within the heart is happening left to right and not right to left as we usually think it should be. Now this is the CT. I will pause it and I will come from abdominal side, and as you can see, this is the aorta, descending thoracic aorta, and we are moving upwards. These are the hepatic veins which are coming. They are joining to form the inferior caval vein. The hepatic venous complex. Actually, inferior caval vein is interrupted, and this is the azygous vein which is continuing upwards. So if you go upwards, you will see that it is directly connecting to the left-sided atrium. We go further, it again shows the same thing, that this is enlarged left atrium, which is also receiving the pulmonary veins. This is a smallish right atrium. We go further up, and this is one of the appendage. And these were the, there was pulmonary stenosis and confluent pulmonary arteries. Now this was the bronchial arrangement, which is like left isomerism. Patient had absent coronary sinus. Patient also had splenic abnormality, and there was left superior caval vein, there was right superior caval vein, and all the hepatic veins were directly connected to the left-sided atrium. And so we thought that this patient is having left isomerism with absent coronary sinus, and all the pulmonary veins were, as well as the systemic veins, were connected to the left-sided left atrium. But the right atrium was also having characteristics of a morphological left atrium. So this was a condition where there was left isomerism. In addition, the patient had left to right shunt as against what we think should be in a patient with cyanosis. And the patient also had hypoplastic tricuspid valve and right ventricle. So when we reviewed the literature, what we found out that if you go into the literature, these are different cases which have been reported as totally anomalous systemic venous connection. And if we go by our own definition, which was emphasized by Professor Anderson, only these cases in this green box will be labeled as totally anomalous systemic venous connection. Rest all we have to think whether that label is correct or not. Now, these are some of the characteristics which I have highlighted again and again in my presentation. Right ventricular hypoplasia, if you can see, quite a few patients, they have documented that there is right ventricular hypoplasia. The cardiac anatomy or the source of pulmonary blood flow has been different. In most of the cases, it is the atrial septal defect which allows this pulmonary blood flow to happen. And rhythm abnormality is also quite common. And some of the patients, although have gone for complete repair, quite a few had to go for BDG or 1.5 ventricular repair path. So what we understood was what is not totally anomalous systemic venous connection, although it has been highlighted so in the literature. Now, what we understood is that if all the pulmonary veins are connected to the coronary sinus, it actually connects to the right atrium or drains to the right atrium. And therefore, this possibly is something which should not be clubbed together with totally anomalous systemic venous connection, because both have different meanings. Here, physiologically, everything is normal, while in the other case, what we are saying is the patient is having significant right to left shunt and desaturation. This is another similar case, and I think these should not be included in the label of totally anomalous systemic venous connection. So what we mean by totally anomalous venous connection are these 7 cases, one in the setting of mirror image and rest in the setting of usual arrangement, including the one which I just showed as the first case. Now, when and how to suspect, because I think a lot of clinicians must be listening to this. So it is my humble duty to share my thoughts, how we should suspect and approach such a case. So if we are seeing a patient who has cyanosis, where we are thinking of congenital heart disease, but it is not fitting in well, where There is no murmur, P2 is normal, and we are not finding any other thing. In addition, there is no obvious right to left shunt. There is unexplained dilatation of LA and LV, or there is left to right shunt across ASD or VSD. Then we must suspect systemic anomalous venous connection, and you can use this algorithm to find out how to interpret saline contrast echo. So I'll skip these, and I'll say if you are injecting saline contrast, then you have to see in which atrium it is coming first. If it is coming in RA, it is normal connection. But if it is coming in the left atrium, then depending upon where you have injected, if you have injected in the left arm, it can be left SVC to left atrium, or unroofed coronary sinus. If you have injected from the right side, then it can be right superior caval vein to the left atrium. And if it is from the leg vein, then it can be IVC to left atrium. And you must repeat from both arm and leg, because these may coexist. And there have been cases in the literature where patient was operated considering it as a case of superior caval vein to left atrium, and the patient continued to have desaturation, and later only the patient was diagnosed as also having inferior caval vein going into the left atrium. So if you want to avoid any such problem, then we must repeat saline contrast from both arm and leg to confirm or refute the diagnosis of totally anomalous systemic venous connection. Now, just to complete the previous algorithm, so it is the same. The saline contrast has to be repeated to confirm and decide whether it is one vein, two veins, or all the veins. And this may not completely tell us about the coronary sinus. If that has to be done, then we may need advanced imaging. If anatomy is only the concern, then CT or MR may be okay. But if the overall plan is to be made, then catheter angiography is superior, because it also gives us about information about pulmonary artery pressure, as was in our case. Now, on the similar lines, based on the right ventricular underdevelopment, this group diagnosed totally anomalous systemic venous connection prenatally. And I think, therefore, this sign of RV hypoplasia with somewhat dilatation of left ventricle is a good sign to suspect systemic venous anomalies. Although in this paper, they did not mention about coronary sinus, and that remains something which should be seen and emphasized as and when we are trying to diagnose systemic venous connection. Now, how to manage these patients will depend upon what is the size of the right ventricle. If it is adequate, we may consider complete repair. If it is borderline, then we may consider 1.5 ventricular repair. But if it is too small, then the patient has to go for a single ventricle path or a TCPC path. In the process, I learned a lot while I dealt with the systemic venous anomalies, and we wrote an algorithmic approach on this saline contrast echo. We using the same concept of lack of dilatation of right-sided chamber, so relative hypoplasia of right-sided chamber. We could even diagnose anomalous systemic venous connection in the setting of vein of Galen malformation. And this is the paper which explains almost everything which I have talked about till now. This was published in Annals of Pediatric Cardiology in 2017. Now, coming to the question which I posed earlier, is our current way of classifying systemic venous anomalies correct? Because the way we classify is anatomic classification based on a location, but it does not provide any physiological alteration. And considering this deficiency in this classification, we suggested a new classification in the textbook, which I think quite a few of you must have read. Now, this is what we propose, that when it comes to anomalies of caval veins, we must divide them into anomalous connection but normal drainage, anomalous connection with anomalous drainage, anomalies of course, and things like that. And this is the expanded version of the same. And if you can see here, only this group is the one which will be presenting as desaturation, while this group will have no abnormality as such and will be found only incidentally. And there can be multiple anomalies, of course, but they remain silent and they may not have any clinical symptoms. So to summarize, totally anomalous systemic venous connection is extremely rare. This term is not apt for the settings of atrial isomerism. Physiologically, it is a type of admixture, and the degree of pulmonary blood flow will depend upon the amount of shunt which is happening across atrial septal defect, ventricular septal defect, or arterial duct. Abnormalities of rhythm, especially the P wave origin, are common. Size of ASD, VSD, or PD determines the RV size, which in turn determines the surgical management of these patients. And I would summarize by saying that carefully performed and interpreted saline contrast echo is useful in identifying the degree of abnormalities these patients may have. Thank you so much for your patience hearing.
Thank you very much, Gupta. It was very, very nice. Thank you. Thank you a lot. Today we have very nice guests. We are happy. Thank you very much for your presentation. It was very good, the same as the other one. And today we have Alan McGee with us and Gil Vernovsky, who usually don't join us on this session, as well as Dr. Silverman, and to discuss. So I will ask Gil to host this discussion, and we are very happy to have him today.
Oh, I'm happy to. Thanks, Grace. I think that Dr. Gupta was a little bit modest, a little too bit modest. He mentioned, whoops, I have my back thing. He mentioned his chapter in Anderson's Pediatric Cardiology. I'm going to see if I can just take this blocker off here. The chapter that he and Professor Anderson and Diane Spicer and Ryan Moore wrote in this textbook is absolutely phenomenal. It taught me such a great deal on this. I wanted to just show you one thing in here as I was watching him. This was this right here, which he showed, that algorithm, was one of the best algorithms I've ever seen that combined anatomic accuracy and physiologic importance, and the way to tie together the anatomy and what to do about the patient. I have never had a chance to thank you in person. So I really wanted to thank you in person for just a fantastic chapter in that regard. And I do recommend to everyone to take a look at that. There are a number of questions that have come up, but I thought I would first turn to Dr. Silverman for comments on this very rare anomaly. And I'd like to hear your thoughts on this from the beginning, Norman, if you don't mind. If Norman is there.
Thank you, Gil. Yes, I must say this chapter is really quite amazing, and Dr. Gupta has thought this out very carefully and clearly. I was just thinking as listening to Professor Anderson talking about the morphological method, how if you assume that an atrium relates to its venous drainage, how this could put you into terrible trouble. And you take secondary characteristics and make them the primary characteristics, you may get the atrial morphology entirely wrong. Bob, can you comment on that?
You've said it all. That's 100% correct.
Oh. I must say, Saurabh, thank you very much for your very clear and reasoned presentation and for your chapter. I think all of the reference material is available within the chapter, is it not? The thing that struck me, being a devotee of contrast echocardiography, is how important it is to do contrast echocardiography and also to look at, as you've emphasized here, not only from above to assess venous drainage, but also to use at least one leg to give you a venous injection. And I think that's, as an echocardiographer, that is probably one of the most important issues that we have to consider. And I'd like to ask you is, as you've evaluated these patients, did you learn anything more from your advanced imaging, or did it simply enhance what you already knew from your echocardiograms?
In terms of these lesions, or in general, Dr. Norman? No, in terms of totally anomalous systemic venous connection, I would say that coronary sinus is quite difficult to image in these patients. So that is something for which we have to go in for advanced imaging. That can't be clarified on echo because when the right atrium is so small, it's very difficult to see whether it is opening in the right atrium or whether it is really not opening there and how it is playing out. So as I emphasized in my presentation also, in both the cases, we had different questions in our mind, and that's how we took different approach. In the first case, the question was how to manage. So we went ahead with catheterization. And in the second one, the question was more about anatomy, and we were not really worried about the pulmonary pressures. So we went ahead with CT to define all the anatomic details. But regarding the coronary sinus, Dr. Anderson will remember, we had a long discussion almost a few weeks back, and we were actually doubting ourselves whether actually coronary sinus was into a left atrium because it's such a rare thing. So we spent almost like 45 minutes to dig it out from the virtual dissection of the data sets to convince ourselves that actually the coronary sinus was connected to the left atrium in this case. So I would say that yes, advanced imaging helps, and it really helps in clarifying things further, but a lot can be made from echo and saline contrast echo putting together.
That ties me into one of the questions that came in, Saurabh, that I think would be interesting for the clinicians to comment on, which is about the risks of multiple contrast echoes in patients with systemic venous anomalies. We certainly think about that in the newborn ICU when patients have right to left shunts and the potential risk of stroke. Do you have any comments, you, Norm, anyone else on the panel, about saline contrast echocardiography risks? Has there been anything been reported in patients with right to left shunting?
So if I can make,
sorry.
Yeah, Professor, please go on. Please go on.
You go, Saurabh.
During our review for the paper which we wrote for saline contrast echo, there is a large report of many hundred patients where they have shown the safety in patients with patent foramen ovale during Valsalva, where they've shown right to left shunt, and they haven't reported any significant abnormality. But that is a different scenario compared to congenital heart diseases, where the amount of right to left shunting is much more. In my personal experience, although we have not collected all the data, but we haven't seen anything significant going wrong with these patients. If we do take care of the air bubbles within the saline when we are preparing, if we are preparing it well, then I don't think it's a serious issue. It can be managed without any difficulty.
Yeah, I would agree with you. There's very little data. There are some reports of problems if you go through the literature on contrast echocardiography, but by and large, it is not a problem. I would merely also enforce that make sure that you don't inject large air bubbles. And I've always used either the patient's own blood as a emulsifying or detergent phenomenon to lower the size of the bubbles, or albumin to coat these bubbles and make them smaller. And they do tend to last, if they're microbubbles, for a very short period of time within the circulation. The number of bubbles that we see injected into the circulation are just in normal circumstances, with the flushing of lines, etc., which suggests that that this is not a major problem. Well, we know it's not a major problem, but whether it's a problem at all is extremely difficult to determine. But the overall impact must be a very small one.
Thank you, Norman. I also want to remind the panelists, if you could keep an eye on the Q&A box and the chat box, if you could type some of your answers there. I think the expertise of the panel, we haven't heard from Dr. McGee yet, and I'm interested to see what your thoughts are, but there certainly are a number of questions in there that I would encourage people to respond to. Specifically, we're going to go to about 10:30. This could be an entire day, as this is an extremely, 10:30 Eastern time. So this is an extremely busy topic. I'm going to move to just a couple of other questions, but before I move to that, Dr. McGee, any comments on the presentation so far?
You're still muted, Alan.
I do beg your pardon, I'm unmuted now. Just to say that Saurabh has a beautiful presentation of this diagnostic process, and also that if you don't think of something, you'll never find it. So as we've taught a lot today about anomalous systemic venous drainage I didn't know about before. It's fantastic presentation. And just about the, I frequently do bubble contrast for evaluation of PFOs for transcatheter closure with a blood air mixture. I've never seen a problem ever.
Hope we keep it that way. All right, I'm gonna move to one of the questions. Let me just get to this. One of the questions that was interesting, where in the concept of the caval veins and the coronary sinus, where do you consider the hepatic veins in that combination of connection, let alone drainage?
Can I make a comment there? Because to me, this again emphasizes the importance of recognizing isomerism. I mean, you probably know more of this than I do, but I think it's exceedingly rare to find the hepatic veins draining into the heart, not through an inferior caval vein, except in the setting of isomerism. I've got a lot of double negatives there. But if I saw the hepatic veins connecting in isolation into the heart, I would immediately be thinking of isomerism. Saurabh, is that fair?
Yeah.
Saurabh knows much
I
more
think,
about the literature than I do.
Yeah, in most cases, hepatic vein, if it is directly connected, either it is in the setting of isomerism or it is not defined atrial appendages.
I have only one comment, Bill, sorry. I want to ask to Bob or Saurabh first compliments, because I saw the presentation of Bob and became amazing with the pre-recording with him. And I am very surprised by your approach. The idea is this: do you think about the classification? We can make some, like we do for pulmonary vein, total anomalous. It means for like supracardiac, cardiac, infracardiac, and mix. This is something that you can make for the type of anomalies you met. And the other things is, if please, we can share in cyanotic and non-cyanotic. I'm sure it will be more easy for clinical point of view.
Yeah, if I answer that question, I mean, the anomalous connection of pulmonary vein is a easy thing, because if it is abnormal, then most of the time there is abnormal connection as well as an abnormal drainage. Here, the connection can be abnormal, but drainage can still be normal. So that is why this distinction has to be approached in this manner. And when we say about supracardiac and infracardiac, then anyway, we are saying superior caval vein or inferior caval vein, which means the same. So in effect, what you are suggesting is there in this classification. But yes, terminologies can be changed according to what we prefer in a given setting, depending upon what others understand. But
assuming they are approved by Professor Anderson.
Yeah, of course. So for that matter, this one is approved by him. So I mean, at least I have that advantage.
That actually brings me up to one of the questions that came up in the chat box that I would like to ask the panel. And this comes up certainly with the training of our fellows, and I definitely don't have a great understanding of this. Could you clarify the difference between what we might call a hemiazygous vein, an azygous vein, what they connect to, what happens when there are two superior caval veins? Is it an azygous? Is it a hemiazygous? In 10 minutes or less. Go.
I mean, that's a great question. I have exactly the same problems myself, because I argue, I mean, azygous, as you know, means unpaired. So we're in big problems there when we get down to the meaning of the word in itself. So I simply prefer to talk about the azygous system, because arguably the hemiazygous system is on the left side, the azygous system is on the right side. So if you have left isomerism, you should be talking about the hemiazygous system. So I would like to cut through all that and simply talk about the azygous system of veins. And then when we talk about interruption with azygous continuation, it's simply going through that azygous system of veins, irrespective of whether it then drains to a left-sided cable vein or right-sided cable vein. But I take your point, the distinction between hemiazygous and azygous introduces additional problems that, to my mind, we can well do without.
Thank you, Ed.
Right, Bob. I just call it an azygous vein wherever it is, because it's an unpaired vein. That's what the meaning of the word is. And the biggest problem that we have with this, Gil, seems to come in when you have an interruption of the inferior cava with continuation of this so-called vein. And then if it comes up on the left side, you call it a hemiazygous. If it comes up on the right side, you call it an azygous. I just dropped the descriptions and call it an azygous continuation.
So tell me how wrong this statement is, because it could be very wrong or just wrong. That an azygous connects to a cable vein and a hemiazygous attaches to an azygous.
I think, no, I don't like that at all.
Just
I will stop saying it then.
In the normal circumstance, that's probably correct, but where you get into trouble most of the time is in the situation of isomerism, where the vein either drains up on the left side or the right side. And I just drop the term and call it an azygous, because it
and then say where it can
the twin. That's what the word
and then
means.
say where it gets connected to. Okay.
Indeed.
That's very simple. That was very helpful. That certainly comes up clinically more than abnormal connections of the superior and inferior venal cable veins to the left atrium, which that case that you showed today, Saurabh, was so complex. There were so many things that were impressive about that case. One was the growth of the RV once the atrial septum was opened. That was truly remarkable, or enlargement. I don't know if it's growth, but enlargement of the right ventricle. The catheter course was a tour de force to go through all four valves to get to the pulmonary arteries. I commented in the box, it looked like a G clef in music, but was inverted. So it was a inversus G clef, Bob. I wasn't sure if that was great. I did have, there were a couple of questions that came up from that in the chat box. One was, what was done with the antegrade flow and the pulmonary valve when the Glen was done? Was that left alone?
Yes, so antegrade flow was kept open, and that's why I showed the pulmonary artery pressure after the first surgery, and the mean pressures were okay. Glen was flowing well, and I mean the later patient is doing quite well that way.
That's truly a wonderful case. It really was. Yes,
Can I
Norman?
just make a comment? I mean, I think that these cases that Saurabh showed you are very important from another point of view entirely, and that's the philosophy of when a chamber is small, is it small because it's intrinsically small, or is it small because it isn't getting enough blood? And I think we make a lot of times, we make these assumptions that are really inappropriate, is that this chamber is small simply because it isn't getting enough blood. I mean, I think that we do this a lot over the aortic isthmus, when there are problems in this direction. But I think that's something that highlighted today by Saurabh, that is a general principle that we have to accept in terms of cardiology.
So there was a paper in JACC 1997 by Foon, and that was regarding hyperplastic left ventricle in the setting of when there is reduced preload. And they showed the same thing. Once the preload is improved, left ventricle actually improves in size. So that has to be kept in mind. In fact, one of the questions in the chat box is also saying how to decide whether RV is really too small to give up on biventricular repair. So I think that will remain a clinical judgment depending upon whether you have encountered such a patient in the past and how they have behaved. With such a small R, I'll be very skeptical if we can think of biventricular repair straight away. Although in the second stage, I think our surgeons were not, they did not agree with me for going for biventricular. But I think there was a good possibility that we could have converted this patient into biventricular repair. But we ended up having 1.5 ventricular repair for the time being.
Dr. Zaba asked a question about that case, which was, how is the right side of the heart filled at all when there's totally anomalous systemic venous return? And I'm imagining that was only the coronary sinus that was in the right atrium and right ventricle, or just the left to right shunt at the ASD?
It was the left to right shunt through ASD. And that's what I'm trying to emphasize again. If we are finding left to right shunt across ASD or VSD in a patient who is cyanotic, suspect there is something wrong with the systemic veins, because there is no business that it should be shunting left to right, which was happening in both the cases. So I think this is very important clue, and there are 2-3 clues which should be taken when we are approaching such a case.
See if there's any last comments or any other questions.
I just wanted to make one comment to Saurabh, to ask him about how you approach the parent when you have to tell them you have to stick their child 3 times for a venous access. Certainly the places where I work, doing it once is somewhat difficult. How do you manage to get to do it 3 times?
Yeah, I mean, I'm from India, so people listen to what we say, and they generally kind of follow what we suggest to them. It's not easy, but yes, they take our words much more seriously than they might be taking in your part of the world.
I think the important point that's come out of all of this discussion is the importance of having the pediatric cardiology textbook edited by Gil Wernowski.
Yeah.
Here we are.
An amazing chapter, and if you see the book is behind me, Bob, I'm the only.
Indeed, I'd noticed that all the time, Norman.
Right over there, ready access, together with another great work that I have right next to me on the other side, which is, I mean, one has to have one's references available in order to do this properly.
This is going to have to be in our conflict of interest forms for Congenital Heart Academy moving forward.
But Gil, we were promised you were going to tell us about the World Congress. You're going.
Yes, I wanted to. First of all, I want to be respectful of everyone's time. I want to thank the over 200 people who have come on to this webinar today. If you have time to stay, it would be greatly appreciated. The 8th World Congress of Pediatric Cardiology and Cardiac Surgery was scheduled to take place in 2021 here in the United States. And I'll tell you a little bit about that in a second. But obviously, due to COVID and travel restrictions and many other things, that needed to be changed. So if people have about a half an hour to stay, I would like to first start with a very brief slide presentation and then an audience poll of some ideas for sessions to have. We've certainly learned that we can capitalize on the 16,000 or 17,000 members of the Congenital Heart Academy now to use them as a needs assessment. So it's not just based on a scientific committee working in isolation that may not be in the real world where everyone on this call practices. So I am going to share just a couple of things with you all now, if I can. For some reason, it's not coming up. Let me just see here. Do you see the slideshow now?
Yeah.
It says the World Congress?
Yes.
Yes, 8th World Congress Pediatric Cardiology.
Great. Okay. So as I said, your input would really be helpful, not just the people on the panel, of course, but everyone out there in the audience, and there's a couple hundred of you. So I'll tell you just a little bit about the meeting. I work with a large team of exceptionally talented people. Jeff Jacobs and I are the co-chairs surgical and cardiology. Katie Dodds is the interdisciplinary chair for nursing, perfusion, psychology, etc. Dave Cooper from Cincinnati Children's and Mitchell Cohen round out the program. I'm going to tell you in about 10 minutes the history of the World Congress, the adjusted dates, a little bit about our partnerships, our partnership with the Congenital Heart Academy, and then we'll do a quick poll for topics. This is just a very quick video while I get the other things lined up. This will last about 45 seconds. Thank you. Bob, I need to get a picture from you of one of the recent World Congresses, and I'll tell you why in just a second. I realized when we made that a while back, and two giants in our field have been lost, Bill Norwood and Paul Weinberg, whose pictures were in there, and we will be dedicating much of the Congress to their memory and others. For people who don't know the history, in 1980, Jane Somerville and others had the idea of having the first World Congress of Pediatric Cardiology, the medical end of things, in London. And that was followed by a second one 5 years later. Welton Gersony was involved in the organization of this, again, with a large committee in New York City. And then the cardiac surgeons had their first meeting as a cardiac surgical group in 1988 in Bergamo. And then that was followed by, this was actually the first one I had the privilege of attending in Bangkok in 1989, pediatric cardiology. And then it was in 1993, really, that it was clear that the cardiology and surgical meetings should not exist separate from each other. And the first World Congress of both pediatric cardiology and cardiac surgery took place in France. That was followed, it was originally supposed to be followed 2 years later in Kobe, Japan, but because of the terrible earthquake that occurred there, the Japanese group organized this 2 years later in Honolulu. So 93 and then 97, then 2001 in Toronto. It keeps getting bigger and more international into Buenos Aires. Wonderful sessions in Cannes in 2009, Cape Town in 2013. The 2017 meeting was scheduled for Istanbul, but due to political unrest, it was then moved to Barcelona on a very quick time frame. To be able to get hotel rooms and a convention center was just a remarkable achievement by Dr. Sisek and his Sirtat Sisek and his colleagues. Many have written about this, and I'll put these up on our website if people are interested in it. Because it's been happening every 4 years, and there's an international bid, people have started to call this the Olympics of our profession. And we were so proud and humbled, actually, to get the award to the USA in 2015. Jeff Jacobs and I have been working on this bid since 2009. So thus far, it's been 12 years that we've been working on the World Congress with our great team. But then COVID hit, as you might imagine. So we made a decision in July that it was important for us to move the World Congress in time. And we decided on 2023, both to get good room rates, actually better room rates, as well as to keep our contracts good in Washington, D.C. So here's the first statement that I'd like you to remember or mark down, that August 27th to September 1st, 2023, hopefully will be a face-to-face meeting. I can't see why it wouldn't be, but we clearly will have other options that I'll talk with you about in just a little bit. We've had 51 societal partners, the Congenital Cardiac Anesthesia Society, the Global Alliance for Rheumatic and Congenital Hearts. All of these organizations will be embedded within the World Congress scientific program. So the CATH program that Dr. Hijazi runs, the International Society for Adult Congenital Heart Disease, the Cardiac Neurodevelopmental Outcome Collaborative, 3 different rhythm societies, the Neonatal Heart Society, the Pediatric Cardiac ICU Society, the International Society for Mechanical Circulatory Support, and the Fetal Heart Society. So this is, for those of you who haven't been to one of these things, they're tremendous experiences where you get to meet people from all over. We currently have 66 institutional partners here in the United States that gave us some seed funding. Another thing, if you'd like to write it down, David Cooper is our financial chair, deals with institutional partnerships. Any questions about your institution's involvement in the World Congress, you can address to David, and his number is there. And I think we're recording this, so this will be shown on the YouTube channel. Mitch Cohen and others put together, and this was sort of, we just had the program done when the pandemic hit. And so we did a ton of work organizing 26 tracks, almost 1,800 talks, 37 cross-disciplinary sessions, over 1,200 speakers from all over the world. I'll tell you about the abstract sessions in just a second. We also are going to have an international village where many societies, the Latin American Society, the Pan-Asian, Pan-Arab Society, Indian societies, AEPC, will all be having individual sessions highlighting what is going on in their areas of the world. So this is quite an undertaking, and we're very optimistic that it will take place as originally planned. Here's the 26 tracks, not only general cardiology, but imaging parts of cardiology, EP, catheterization, adult, heart failure, transplant, cardiac surgery, along with mechanical circulatory support and perfusion, ICU and anesthesia. And then some new ideas that we have: big data, new technology, artificial intelligence, administration, basic science, pulmonary hypertension, sudden cardiac death in the young. We're going to be having a special neurodevelopmental track. And of course, this is a global meeting. And one of our largest tracks is on global cardiac health, and the rheumatic heart disease track will be the largest that has ever occurred in one of the world congresses. I don't have it on here, and after I make the presentation, I'd like to ask the panelists and everyone. One of our preliminary ideas is to have a futuristic anatomy lab where we will have both specimens and experts like Professor Anderson and Diane Spicer and others with specimens, 2D imaging, surgical imaging, 3D imaging, 3D printing, holding malformed 3D printed hearts, as well as surgical procedures. So this anatomy, a huge room, will allow people to really get a hands-on feel for complex things that we've been talking about, particularly in Norman and Bob's series. We also are going to have a very large nursing session based here in the United States, where we have tens of thousands of active cardiac nursing people who help take care of our patients. And these are the types of things that will be in those nursing sessions, as you can see here. And then the last thing I want to talk about before moving to a poll is what we're going to call the best abstract in the world competition. There's usually about 1,000 to 1,200 abstracts. I would encourage everyone on this call, if they're interested, to submit an abstract. And they would be submitted into one of 16 different abstract categories, as you see here, that will have their own abstract presentation, a 2.5-hour presentation of the best 8 of those abstracts. Through an audience responsive system, we will then get 16 winners. So we'll have, for example, the best ICU abstract, the best nursing abstract, the best neurodevelopmental abstract, the best fetal, et cetera, et cetera. And then on the last day, they will each be represented. So you can sit in the large hall with 4,000 of your colleagues and hear the best abstract from a particular discipline that maybe you don't follow all the time. And again, we'll vote on the best abstract in the world. So that's the program update. One of the things is that much of the science that we had planned on will become somewhat dated. So we're very pleased that we have 4 educational partners, one of them being the Congenital Heart Academy. And we are going to present over the next couple of years some of the plenary sessions that we were planning to present this year in Washington, D.C. A couple of examples would be the new guidelines on management of hypertrophic cardiomyopathy. That allows us to create a almost completely new program, but still present over the next 2 years what we have put together and not let it, so to speak, go to waste. So this is where I'd like all of your input, if possible. If you could scan this QR code, it'll take you to a website. You also, and I think that Grace put it in the chat box, if I remember. It will take you to a, is it there as well?
Yep.
Great, thank you, Grace. It'll take you to a website where we're going to, or you can open up another web browser. And that is ahaslides.com / and then all in caps, WCNEEDS. And I'm going to go back to my desktop here, and I should be able to close this. And open, that now I see what's happened. Okay. And are you seeing that now with the QR code? If you want to scan it one more time. Grace or Sasha, is that coming up on the screen before I move forward?
Yes,
Yeah.
yes, I even scanned.
Oh, good, good. So, great. You can see down in the right-hand corner as people join online, the number of people who have an opportunity now to participate in our program. So Mitchell and myself and others, like many of us who design scientific programs, we get the topics right most of the time, but it wasn't until we really started to ask the audience what they thought would be important, not only for topics, but duration of sessions, types of sessions you like and you don't like. And this will give us a good opportunity to do that. So I thought we would start with just a few basic questions of those of you who are logged on. So when you do your answer, you can make your answer and then you hit submit, which is what will allow you to get to the next question as soon as it is posted. And Grace and Sasha or Norman, I'm going to count on you to say if we're going too fast or too slow. So this is just a first question on the audience makeup, so we get an idea of who is answering this poll. Looks like we have about 60 of you on here. I really do appreciate it. If anybody else would like to jump on, you can open up another browser window and type in ahaslides.com/WC needs. I'll move to the next one here, which is my age bracket. Sasha and Grace, this will give us an idea of this particular session too.
Yes.
People a lot younger than us, Bob.
Yes.
That's great. Thank you all for doing this. And I'll again go into the needs as we go ahead. If you could check in with your gender. That's usual. We usually see about 60-40 as a breakdown here. Oh, good. Some more people are joining in. I sure appreciate it. So you can open up another browser window or you can use your phone and go to, it's at the top there, ahaslides.com/WC needs. What best describes what you do every day? So that's general cardiologist, fetal cardiologist, imaging, electrophysiology, cath, adult surgery, anesthesia, perfusion, ICU, staff nurse, advanced practice nurse, physician in training. And it's interesting that
Echocardiographers down there.
Say that again?
No echocardiographers on your list.
I have imaging.
Oh, okay. All right. Imaging is fine.
And, you know, of course, we get so subspecialized here in the US, but so many people, I suspect, on this call do all of that stuff. So it's great to have an international audience, and we really thank you for that. But that's a good point, Norman. I'm going to change that to echo/advanced cardiac imaging or multimodal imaging for the next one. Thank you. So at this point, we're planning a 2020 an in-person model in 2023. I have to tell you that with the 17,000 people that have come on in the Congenital Heart Academy, we realize that many, many people don't have the option to attend an expensive meeting and traveling. And what we're learning in this meeting and Heart University and others is how important it is to put this information out globally as enduring materials. So it'd be nice to get an idea, again, of the people who are filling out this survey, what is their likely way of attending. And of course, we're not committing anyone. This is just the where we are right now. And for the 1.4% who are not planning on attending, please tell me why, and we'll figure something out for you. Thank you. Moving on to the next. Are continuing education credits important to you? Very important, not sure. They cost money to do. They are very challenging for people that don't know. If we're giving credits, each speaker needs to give 3 objectives. They need to be evaluated objectively. If they are important, we are currently planning to do the CME through Johns Hopkins All Children's and the CEU education credits through the Children's Hospital of Philadelphia. Do you think it's likely that you will submit an abstract? This is great. And again, if anybody tuned in later, you'd like to jump on, please go to ahaslides.com/WC needs. If we have nurses on, we want to get an idea of the nursing population that are likely to come. So if there are any nurses on, if you will be submitting an abstract, that would be very helpful to know. And remember at the bottom of each question to hit submit. I had to find an Uncle Sam here. Okay, so this is what's called a word cloud. And we're going to have these large plenary sessions, 5,000 people in a room with the best speakers we can put together. What do you think is the most important topic to present in a large session such as that? If you type that in and hit submit, use relatively short phrases. It can be a congenital heart disease. It could be rheumatic heart disease. It could be financial issues. Whatever you think are the most important topics. I agree with that one, but that's my bias. I love which ones come up first. These word clouds tend to be really fun as we start to get 4,000 and 5,000 people answering the questions. If you want to just write Professor Anderson, you could write that in there as well. I'm going to give this another 10. Oh, COVID-19, a great idea. Great. These are all terrific ideas. Thank you. All right. While you're thinking, typing in those ideas, these again are the large sessions that every cardiac practitioner, no matter what they do, should know about in 2023. But then we're going to have smaller subspecialty breakouts, maybe 1,000 to 1,500, a couple different subspecialties together. So these aren't the really most important ones, but something that you specifically think would be most important for you in a subspecialty breakout session. And there's going to be time later on to type these, not in a word cloud, but think about, if you're going to travel or you're going to get online, what are the things that are the most important things you'd like us to review? And remember to hit submit when you're done. You can do 3, up to 3 on these. Dr. Gupta, I don't see anomalous systemic venous return on here yet, but I know that's probably one of the most important ones. I'm still blown away by how great that session was today. I just thought it was terrific. Oh, these are great. Keep typing them in. I don't want to have too much time on here, so I'm going to wait about another 15 seconds. It's currently 10:47 on the East Coast. And I think we're going to go for about another 10 or 15 minutes, just so people can plan their time. I'll let this go through one more transition here. A lot of arrhythmia. Excellent. This is a new program by this company. Obviously, as the pandemic has come along, there have been a lot of really creative ideas of how to make interactive sessions on Zoom. I, like I'm sure everybody else, just miss seeing everybody. I miss seeing everybody in probably the most important track, which is the hallway track, where you get to talk about research and you get to find out how people are doing. And I personally can't wait till we get to a face-to-face meeting again. So the next half a dozen or so are on plenary sessions that we had planned. And if we were to continue to have these types of plenary sessions, just give us an idea. If you would be likely to go to a large plenary session on primary cardiomyopathies as it relates to sudden cardiac arrest. Sasha and Grace, this is, I think, going to also be very important for us to think about what would be sessions to present in the Congenital Heart Academy that had already been planned. So we'll keep all of this in mind, because the science in 2 years is going to be different, and we may as well present what people are interested in now soon.
Yes.
The next one is, what about hypertrophic cardiomyopathy, not just from sudden death, but consensus and controversies? You know, as someone like myself who deals mainly with congenital heart disease, inpatient, mainly neonate, I can have a very myopic lens about what's important because I don't work in the outpatient department. It's been really terrific for me to be sure that we plan the World Congress with both lenses on. So this is clearly an important topic. What about, we just had CHA just had a wonderful session on the 76th anniversary of the Blalock-Taussig-Thomas shunt. And in 2023, we will be almost 80 years since we've been treating tetralogy of Fallot. So this was one of our planned plenary sessions, one of the most common surgically approached lesions in the world. Can go from fetal imaging to anatomy, through newborn and infant management, and then what happens over the long run. For those of you who were on the session, we had a 77-year-old gentleman who had who was the 44th person to have a Blalock shunt done by Blalock. And he had his repair at age 21. And it was one of the most inspiring sessions. It's on our YouTube channel if anyone is interested in looking at that. It was just terrific. Self-care has been a very important topic. So, you know, if we don't, especially during COVID, if we don't take care of ourselves, how are we going to take care of our patients? Would this large plenary session be something that you would be interested in? As a definite, probable, might attend. Yeah, these are going to be quick. You can continue to answer while I move on to the next one. Katie Dodds put together a panel that was going to be in the morning over coffee with the people who led nursing science: Patty Hickey, Martha Curley, Mary Fran Nazinski, many, many people who advanced the care of cardiac nursing. And this will be very helpful of gauging the size of the room that we might need, and if this is something that you would go to. Okay, this one I found very interesting also. So we have been talking about ductal PDA treatment forever. And then when surfactant came around, all of a sudden there was a whole new population of very low birth weight babies that were surviving but had a patent arterial duct. So the idea by the Neonatal Heart Society and the Critical Care Society and the Cath Society was, what is the right way to approach the ductus in a very low birth weight baby? Is this something that you would definitely attend, probably attend, et cetera? And especially now with the Occlutech PDA device, great experience in India with that, has been phenomenal, and really has changed a lot for these babies to avoid a thoracotomy. We're going to be about 50 years since Guillermo Fontan and Billy Kreutzer described right heart bypass as treatment for the Fontan. And again, fetal flow, surgical management, ICU management, long-term outcomes. Sometimes we spend disproportionate amount of time and resources on functional univentricular heart and its management. But this is certainly a topic that many, many people are interested in, as I see here. Rheumatic heart disease, how to advocate for a disease of global inequity. This will be a real opportunity for us to look outside of, certainly as someone who lives in a privileged country, who doesn't, I don't deal with this very often, but it's such a global problem. And I think that this will be important for us to know what number of people might want to come to this, this session. The SVR, we're talking about collaboration now. So the SVR, or the single ventricle reconstruction trial, the NPCQIC is the National Pediatric Cardiology Quality Improvement Collaborative. That's here in the United States. And Cardiac Networks United, for those of you who don't know, are a collaboration between the ICU groups, the Neurodevelopmental Outcome Collaborative, transplant. You know, the internet and databases have allowed us to collaborate in ways that we've never been able to before. So we were thinking about a session that might be of interest to people, and that's what this might be about right here. I appreciate everybody's time. We're coming across to the top of the hour, so I'm going to move through fast. And again, if anyone would like to jump on, it's ahaslides.com/. WC needs, and it's at the top of the slides here. Improving the delivery of healthcare systems in low and middle income countries. We very much appreciate all of your input here. And it will be in 2025 will be 50 years since the first successful report of an arterial switch by Professor Jatin in Sao Paulo. And again, same issues as tetralogy and functional univentricular heart. Where do we stand now, decades later? What have we learned? What are the unanswered questions? The Centers for Disease Control here in the US are putting on a session of all of the international registries and what can be learned, again, in collaboration from those sorts of registries. I don't have the names of them off the top of my head, but I know the IQIC is one, and there are a few others there. Those are sort of the big sessions. Here's a couple of different types of sessions. Do you enjoy debates or do they get too silly? So, some of you have seen them. And again, this is as we plan our sessions, it's helpful for us to know about the interactivity of these sessions. And this will be technology very different. So now I'm going to shoot very rapidly. This is from our Fetal Heart Society. Pick up to 6 of these fetal topics, even if you're not a fetal cardiologist, that you might want to go to. So you just hit up to 6 and then hit submit, please. And if you wouldn't go to any fetal topics, please hit none. This is supposed to be an I would almost certainly attend. A few more seconds, and now we're going to go to the other end of the spectrum. In adult congenital heart disease, you would almost certainly attend one of these sessions. Pick up to 6, and if you wouldn't go to any ACHD topics, please check none. Sasha, again, these are going to be helpful data for us and Grace moving forward for the curriculum for 2021, which we're in the process of planning. And we do thank everyone who's participating with the Congenital Heart Academy. It's probably been one of the most exciting and rewarding things in my career. One of the few good things that has come out of the pandemic is getting to spread all of this so far around the world. And I think my colleagues would agree. I'm next going to move to neonatal cardiology. If you're interested in neonatal cardiology or not, if you don't think you would go to any of these sessions, please click none. But if you were going to go to any of these neonatal sessions, please click yes, up to 6. Many people interested in neonates. Excellent. You know, this is only the second session that I've done this with. I'm really curious as we get up into the thousands, how these bars all change. Here we go now with outpatient or ambulatory cardiology. You could click none, but this is, it's hard to, in my view, it's hard to pick 6, but what do you think would be the best 6 sessions here for those of you that do pediatric cardiology in the outpatient world? Or let's say you're a surgeon, what would you like to go see? For example, evaluation and management of connective tissue disease or coronary artery anomalies. Again, the link is at the top if anyone has come in late, and I appreciate the 150 of you who have decided to stay with us. I'm going to move to the next one. These are going to be driven by the interdisciplinary team, nursing, critical care, perfusion. You can look across them. If none of them interest you, that's cool. just check none. If there are some that you think you would definitely attend, please check them off as well. It's interesting to me, and I know Norman and Bob, you guys have been around for a long time, Alan as well, that, this started out as a small group in London. And it was mainly cardiologists, and to look at all of the different types of people that now really bring their expertise to improving care for these kids and their parents, it's truly amazing, and involving them in the faculty will be truly a lot of fun. Here's some surgical topics that the World Society for World Society for Pediatric and Congenital Heart Surgery have proposed. If you're not interested in the surgical topics, click none. But if there's up to six that you think would be of great interest to you, please click them off as well. We're getting toward the end. If there are questions we didn't ask, or there's other ways you think you'd like to help, that's going to be coming up at the end here. 5 more seconds, and I'm going to move to the next. This is a funny question to look at, but there's 3 types of sessions that you could sit in. And one of those huge ones with 4,000 or 5,000 people that are those focused plenary topics like we talked about before. The second, that's blue. The second type is in yellow, which is where you get a couple of disciplines like surgery for ACHD that come together, 500 to 1,000 people. And then there's small sessions where you sit with your specialty and your specialty alone. If you could rank, you only get 1 per type of session. What is a 5? You may not like it as a 5. What's a 4? What's a 3? So we can get an idea of how many of these sessions to actually scale. I hope that made sense. If that question didn't make sense, let me know. This is relatively new on the AHA slides. And it looks like it's probably going to end up that everybody likes everything because one is not dominating over any other. Okay, I'm going to move to the next one. I know, yes, it's unbelievable. I'm sure we missed something, and this is the part where, of course, we can't open up the microphones because we could go on forever. But if you could, this is a free text. The results are hidden. If we've screwed up here, please let us know. If there are topics you think we should absolutely cover, please enter those. You can answer more than once, put some ideas in. The next one is going to talk about potential faculty members. So please don't list them here, but this is just ideas for the scientific sessions. Any ideas that you have, and we are going to look, I promise, we're going to look at absolutely every one of these. Is that coming up on your screen, everybody? Because I see nothing being entered just now.
We are confidential, doesn't it?
Yes, but I just wanted to be sure that you're seeing them on your phones because I can't tell.
Gil, probably you have to click show results.
Got it.
Because you have.
Yes, we can see the text box.
I just want to be sure you see the question. Yeah, the results I'm keeping confidential.
Oh, okay.
So just type in your answers and hit submit. And it looks like 76 of you, 77 now have put in an answer. Thank you. I'm going to wait about 5 more seconds. And this is about speakers. And this is important because sometimes we don't know of speakers that we don't see in meetings that we go to, but you might know of excellent young faculty who really need the chance to get their first exposure in a World Congress. If you know of those people, please put their names in here. We then can look up PubMed and look up Google Scholar and see what their interests are. Sometimes we go to meetings and we hear the same old people do the same old things. So I think it's important that we get your input for some speakers here. All right, I'm going to move this now to, again, here's a word cloud. Put a few more topics up there. Now that you've seen sort of what the whole program looks like, enter a few more, up to 3. Yep, and just hit submit toward the end. I think I may have one or two more of these, and that's it. And this has been really, really helpful, everybody, moving forward. It's going to, I'm going to put some email information up for you here at the end. We have 30 months to go. So all of the things that the organizing committee learned and in retrospect could have done better, we're actually getting a reboot of this because we get to replan the scientific program. So this is particularly helpful, especially to see what kinds of things we may have missed. And I can promise you that the 5 of us are going to be looking at absolutely every single suggestion here. Bob, we got development and embryology up there. Excellent. It's truly amazing when I think about the stuff that you showed today that's being done with the sequencing and the ability to see what we had to assume from mouse hearts. It's just remarkable. And there's going to be a huge part about that as we move into the 2023 planning. So again, thank you very, very much for your time. It's 5 minutes after the hour. If the poll is still open, we have a new email address, which is info@WCPCCS, which is World Congress of Pediatric Cardiology and Cardiac Surgery, 2023.org. Our website is being redesigned. The prices are going to be lower than any previous World Congress. We will have something online. This will be the most technically advanced World Congress to date. We've learned a lot through the pandemic, and we are open to any suggestions that you all have. So I do appreciate everybody sticking through. And Bob and Norman and others, we're going to talk offline about how we can make this anatomy lab from Maud Abbott to computer generated stuff. I mean, we have a great opportunity here to use
Can I just comment on that, Gil?
Please do. Yeah, please do.
We're moving forward in the Congenital Heart Academy for that. And in fact, in the March series of presentations, together with Diane Spicer, we're going to start a virtual congenital heart archive. So we're going to be making video presentations of hearts. Diane Spicer is going to be the main mover in this. She's already made video clips that she shares with Sasha. And I'm going to be joined by Rohit Lumba, who is in charge now of the Lev Archive in Chicago. I'm hoping that Justin Tretter will also join us from Cincinnati. I'm going to talk to my other colleagues, and what we're going to try to do is we're going to put video clips together so that using the amazing facilities that, as you say, Zoom has brought to us, has permitted the Congenital Heart Academy to bring to us, we're going to try to create a virtual archive so people who don't have access to specimens will be able to see the specimens presented. And we're going to take given topics. So in March, we're going to start off with the univentricular connection to the dominant left ventricle. And we're going to show the various variations which Norman has asked us to demonstrate. And we think this is the way forward. We're going to do it virtually. And this way, we're hoping that by combining the hearts that are in different archives, we can cover the overall topic.
Perfect. The lessons you learn. I had spoken with Justin briefly about this. Justin's been involved in the very preliminary ideas. So again, we're going to learn a lot from CHA, from Zoom, from things that work, from things we could improve on. And I'm looking forward to your input. And obviously, we're going to be involved. Both of you guys, we're going to be involved from the beginning. And now we have some time. Again, nobody wanted the pandemic, but this is giving us an opportunity to learn things that are going to really improve learning. I think it's fantastic.
I mean, there's no question about that. And I mean, what we're learning through the Congenital Heart Academy and what Grace and Sasha and yourself are doing, now, as you say, the very fact we're able to bring this on a weekly basis. Today we had 240 odd people.
Someone just checked in from Sudan.
There you go. And
we would not have reached this type of place without Zoom. So it's
absolutely. And I think the ability to share, because I mean, we know that archives are rare as hen's teeth these days, and we need to preserve them. And I think the virtual means of doing this is the way to preserve what we have and to improve upon it all the time.
The Stratasys company, which does the 3D printing, I'm hoping that we could sort of look, and these are all preliminary ideas, but I'm hoping that we could say, okay, here's a congenitally malformed heart with double outlet right ventricle, et cetera, et cetera. And see the specimen, print it, and have the surgeon do the intracardiac baffle in the room at the same time. That's the direction that we are planning to do for the hands-on part. The visual stuff is perfect also, but we can actually take take something from the Lev collection or another great archive, and not only see it and not only do a 3D image, but do a print of it, so the surgeons can then work on baffling the LV to whichever great vessel they would like to. These are just wonderful opportunities.
I mean, the other thing, of course, is you can do it virtually. I mean, for many places, the cost of printing is extortionate, and I'm a great believer in also doing things virtually.
By the way, Gil, Jeff Jacobs has got some wonderful examples of creating the outflow tract baffle in tetralogy, which he's done surgically. And I think that would be wonderful for the trainees to understand, because in their programs, they aren't getting a lot of time to go to the operating room to see or understand surgery. So I think that having a virtual surgical repair with a printed model would be absolutely phenomenal.
Yep, that'll be the plan. All right, I do have another call that I'm going to need to jump. It was so wonderful to see you both today.
Yeah, great to see you, Gil. You look well.
Thank you. I have a lot of fuzz behind me back here. I've decided to grow my hair out. I'm going to get a ponytail soon.
Yes, one needs, when one gets to a certain stage in life, one needs to have a ponytail to cover the bald spot. Otherwise, you have to wear a kippah.
It'll stay better too. That's right.
Hey, Gil, I'm waiting for a phone call from you sometime, eh?
Oh yeah, I will. I'll drop you a call. Things have calmed down a lot here.
Okay,
So
I'm ready for you.
I'll give you a shoot.
Gil. Great.
Saurabh, thank you. That was terrific today.
Saurabh, you were
Saurabh.
fantastic as usual. You know, I'm envious, Saurabh, of the volume of patients that you get to see. I've always worked in a relatively small volume program, and in a relatively small volume program, your chances of coming across things like total anomalous systemic venous return are not that frequent. So certainly the volume and the excellence with which you do it is much appreciated.
I mean, I wanted to say thank you everybody for generous comments for the presentation which I made.
We are receiving a lot of compliments, Bob, from all over the world. We are very happy, and again, the presence of Gil was important, but we will continue next Friday. The idea is growing, the family is growing, and we are very happy.
So next Friday will be important because we will begin. Diane will be with us next Friday. This is something she and I will do together, but we're going to move on with incorporating the video clips. It's down to Sasha to edit it all, but I'm sure he's going to do a great job. So we look forward to seeing you all next Friday.
Hey, Bob, I can hardly wait. Is it a ventricular septal defect, a bulboventricular foramen, or an interventricular communication?
You will learn the difference between all of them, and you'll learn how it's all to do with
we will all learn
the interventricular communication.
Norman, there is a Bill Lutin that sends regards. I don't know from where. Yes, I know him. He's in Augusta, Georgia, the seat of the Masters golf tournament. Yes, I know him. That's great. I should give him a call.
Can I make a comment here? If Professor Anderson agrees, then he was talking about virtual dissection. I mean, if it suits the preferences of all the panelists, then we can have a kind of session where we can demonstrate how it can be done without using expensive softwares, because that remains a challenge for quite a few people.
I think that's a great idea, Saurabh, and we'll work on that because, I mean, you are the expert of how it can be done with Horos and the PC. And
Yeah.
I think that for the type of audience that we're talking to, it's very important that you, so we will work on that.
Right, sir.
Yes, we are from Japan, Bob, people from Japan, so amazing. I don't think more virtual. This is the normal life became. It's not more virtual. But it's okay. See you on Friday. Thanks,
Yes,
Norman.
indeed.
See you tomorrow.
Bye. Yes.
Bye. Bye.
See you
Bye.
next week.
Bye.
And
Bye,
stay
everybody.
meeting
Take care.
tomorrow, guys. See you.
Thanks,
Bye
Grace.
bye.
Yes.
Bye
See you
bye.
then.